Hello everyone, we are back with the next session of the gynecology lectures, and now we are starting properly with the pathology in cases of gynecology. So one of the most common pathology what we find in gynecology cases is fibroid uterus or leiomyoma. Fibroid uterus or leiomyoma is a huge topic covering everything, so we'll be studying it in detail but in pieces. So this is the first lecture telling you about fibroid uterus or leiomyoma. What do we mean by each and every word we will be talking about in a short while. So this is the most common benign tumor of the uterus. What does that mean? Most common, benign and tumor. Everything. Tumor means all of us have read in our pathology thing that it is the uncommon growth of the cells of a normal organ. So that growth can be benign or malignant. Benign means it will stay at its own place and it will not cause a cancerous growth per se. In a few percent of cases it may grow malignant, but in most of the cases it will stay at its place. That's why it is benign. So in cases of uterus, the most common benign tumor is fibroid uterus, and it is the most common benign solid tumor of the female, not the ovary, the uterus. The uterus, and that too fibroid, is the most common solid tumor, benign, of a female body. What is the histology and histogenesis of fibroid? What do we mean by fibroid? See, all of us know that this is a normal uterus. It contains a layer inside which is endometrium, which we studied in the menstrual cycle, where the changes occur, the hormonal changes. And this is a total muscular layer, muscular plus fibrous layer. It is the main thick myometrium. Myometrium means muscle metrium. And this is the serosa. It is the outer layer of the uterus, which is generally covered by the visceral peritoneum up till the isthmus part, right? So it is as such an extra peritoneal organ. It does not lie inside the peritoneum because the peritoneal covering is from anterior to the posterior side of the uterus. Now we are mainly talking about the myometrium layer, that is the middle one and the thickest layer of the uterus. I hope I am making myself clear. So it is composed of a smooth muscle and fibrous connective tissue. So this smooth muscle and the fibrous connective tissue, when it grows, it forms a round tumor, and that is called as leiomyoma. See, myoma, muscle, or a myoma, or a fibromyoma, fibrous tissue and muscle tissue. So fibroid is basically a misnomer. It is a layman term which understands fibroid, but a more better terminology is a myoma or a fibromyoma, saying that it consists mainly of the muscle and the fibrous tissue. It arises from, important, neoplastic single smooth muscle cell or a myocyte. So a single myocyte, that means single cell of the smooth muscle which becomes neoplastic. So it is monoclonal, very important. All the cells of a fibroid or a leiomyoma, they arise from a single myocyte, and then it becomes neoplastic and gives rise to a benign tumor named as leiomyoma. The stimulus for initial neoplastic myocyte transformation is not known. We don't know why a fibroid is made, what happens and why a fibroid is formed. It is unknown. Still, there are some theories that we'll be talking about, but to understand from this slide that it arises from the myometrium, it consists smooth muscles, fibrous connective tissue. So fibromyoma is a better term. It arises from a single myocyte, so it is monoclonal. Now what is the incidence? What is the definition of incidence? That percentage of cases found in the general population. It is so common that 20% of the women at the age of 30, as the age increases, the incidence increases. So at the age of 30, 20% of the women have got fibroids in their wombs, and 50% of them remain asymptomatic. If a woman is having fibroid in the body, it does not mean that she will be having symptoms. Sometimes an ultrasonography is performed due to some other symptom, and incidentally we find, oh, she has got a fibroid. Now what are the risk factors for leiomyomas? These are important from your exam point of view as well as from your clinical point of view. What things will raise suspicion? Increasing age, I already talked about. It is very rare that a young woman around menarche will get a fibroid, but as the age advances around 30 to 40 years, the incidence of fibroid or leiomyomas increases. Early menarche, important. See, fibroid, because it arises from the uterus, and the uterus is a functional organ. It functions under the effect of hormones, estrogen and progesterone, which are chemical at the end. So they are estrogen dependent tumors. The chemical, the hormone, the estrogen, more and more the presence of estrogen is there are high chances of the woman getting a fibroid. So early menarche means the woman has started ovulating at an early age. So since a long time she is under the effect of estrogen, so the chances of having fibroid increases. Nulliparity. What does nulliparity means? That she has never born a child in her lifetime. That means she has never stopped ovulating. That again says that she is under the effect of estrogen all the time. Obesity and increased body mass index means increased fat in the body, and we know the peripheral conversion of estrogen. So in the peripheral adipose tissue, it is the estrogen is formed. So in cases of obesity, polycystic ovarian disease, increased body mass index, there are hyperestrogenic states, more estrogen in the body, so more chances of making a fibroid. See, polycystic ovarian syndrome, what does that mean? PCOS, we will be talking about this in detail, but in PCOS there is anovulation. The ovary does not ovulate, so there is no progesterone, unopposed estrogen, hyperestrogenic state can lead to fibroid. So at the end, hyperestrogenic state due to any reason may lead to fibroid. Black woman, okay, this is some racial distribution. High fat diet, fat again is a problematic thing, and a family history. What are the protective factors? These protective factors are opposite to the risk factors. So if early menarche is a risk factor, so late menarche is a protective factor. Definitely less time she is having estrogen in the body. Multiparity, that means so many times she has stopped ovulating, so many times there were no menses, there was lactation, which are protective factors for fibroid. Menopause, now there is no estrogen in the body, so no chance of increase in the fibroid. Combined oral contraceptive use. Combined oral contraceptive use means what? Combined oral contraceptive are pills which contains very low dose estrogen, but it suppresses ovulation. So the endogenous estrogen is not formed. Then there is anovulation, and when there is anovulation, because of the low dose estrogen, so there is no high estrogenic state in the body, so it is a protective factor for fibroid. Smoking, what does smoking do? Smoking actually works on aromatase enzyme. It stops the function of aromatase enzyme, and as I have talked in my previous lecture that there is two-cell, two-gonadotrophin theory. So the final production of estrogen is under the effect of an hormone named this enzyme aromatase. So the smoking, it stops aromatase from working, so less estrogen, and it is a protective factor for fibroid. Now, etiology. Why a fibroid is formed? As I talked earlier, that why it is formed, why the myocyte becomes neoplastic, no one knows. But there are some theories which people say that chromosomal abnormality in chromosome number 7 and in chromosome number 12, there are some rearrangements or deletions in the women who are carrying fibroid. The studies have found that in chromosome number 7 and chromosome number 12, some rearrangements and deletions were found. So we can predict that these women can get fibroid in their life. And there are some polypeptide growth factors, namely epidermal growth factor, insulin-like growth factor, and transforming growth factor B, which are under the effect of estrogen, and at the end estrogen is the culprit. So estrogen will affect these growth factors and they will stimulate the growth of a fibroid. Now, growth of leiomyomas. How is it formed? At what rate it grows? It is not a very fast growing tumor as compared to the ovarian tumor. Some ovarian tumors, they grow at a very rapid rate, but leiomyoma is a slow thing. It takes around 3 to 5 years for the fibroid to grow sufficiently to be filled per abdomen. Generally, if you will follow a patient of fibroid who is asymptomatic, see, in every case of fibroid, surgery is not indicated. We will be talking about it in the next class. But if we have not operated upon a patient of fibroid, what will we do? We will monitor the fibroid whether it is undergoing any change or not. By sonography, we generally monitor the size of the fibroid. So it remains either still or it grows very slowly. But if it grows fast, then it is an alarm. A fibroid may grow rapidly where? Either in pregnancy. Pregnancy is a hyperestrogenic state, high hormonal milieu. So in pregnancy, it can grow. There are degenerations. Degeneration means there are changes which occur inside the body of the fibroid. What are these changes? We will be talking about. But yes, if a fibroid undergoes degeneration, it increases rapidly in size. And at the end, but very important, malignant change. In only 0.1% cases, we find that this leiomyoma may get converted into leiomyosarcoma. And then we have to be beware of that situation. So a patient in which we have not operated upon on fibroid, we have to keep a check on the size of the fibroid. The size may increase rapidly in cases of pregnancy, degeneration and malignant change, right? Leiomyoma is predominantly an estrogen dependent tumor. Take home message, please remember this. Estrogen is the culprit. Both estrogen and progesterone receptors are found in higher concentration in the myoma cells. But myoma cells have higher levels of the enzyme aromatase. This increases the high local levels of estrogen. So as I told, why smoking is protective? Because it stops aromatase. But the myoma cells have got high enzyme aromatase. So there is high local levels of estrogen, and that's why it keeps on growing. Fibroids are rare before menarche because there is no estrogen, and majority of them decrease following menopause. These are the points which support this theory that they are estrogen dependent tumors. Before menarche, we hardly find a fibroid, and after menopause, they start shrinking in size. And they often enlarge during pregnancy. In pregnant patients with fibroid, we have to be very careful. Hypoestrogenic states, what are those? We talked about it like before menarche, after menopause. But yes, there are some drugs like GnRH agonist. GnRH agonist at the end decrease the hormonal milieu in the body. It causes an artificial menopause like situation. So if we are giving GnRH agonist to the patient due to some reason, in cases of fibroid also we give it, it reduces the size. Hypercellularity of myomas or cellular leiomyomatous are less common. What does that mean? That the number of cells do not increase that much, but the size of the cell increases under the effect of the estrogen. However, most cellular leiomyomata have a benign course and prognosis. Myoma cell contains more estrogen receptors than the adjacent myometrium. So we know that in the myometrium the fibroid increases. This is also under the effect of estrogen and this is also. But because of the high local level of the aromatase, the estrogen works more in the fibroid and the size increases. And it is frequently associated with anovulation, that we studied in menstrual cycle also, that anovulation is a state where ovulation is not occurring, corpus luteum is not forming, so there is no progesterone. So estrogen becomes rampant. Whatever it wants, it does, and whenever it does, it creates problems. Now, this is a classification based on the anatomical location. So by now this time we understand what is a fibroid, how it is formed, what is the role of estrogen, and what are the risk factors and protective factors. Now if we have got a patient of fibroid, how will we classify the patient and what will we do with it? How will we understand the symptoms and the pathology? So it all depends on the anatomic location and the size also. So this is your uterus with the cervix. This is the level of the isthmus, this is the fundus, and this is the whole body of the uterus. I hope I am making myself clear. So any fibroid which arises in the body is called a body fibroid or a corporeal fibroid, and any fibroid which arises in the cervix is called as the cervical fibroid. Now in the body fibroid or corporeal fibroid, which are more common, most common is the interstitial or the intramural, 75%. Interstitial or the intramural fibroid is 75%. Subserous fibroid, what does that mean? I told that this is serosa. The external layer is serosa. So any fibroid which is located here just beneath the serosa, subserous, it is only 10%. And the endometrium is also called as the mucosa. So any fibroid which is located over here is submucous, just beneath the endometrium or the mucosa. So depending on the location, it could be intramural, subserous or submucous. But depending on the incidence, most common is the intramural, that is 75%, subserous is only 10%, and submucous is further less, which is 5%. Now intramural, once it is intramural, means intramural, but subserous is further divided into plain subserous or the broad ligament, which is a pseudo broad ligament fibroid. We will be studying it in detail, or a wandering fibroid or a parasitic fibroid. I will be telling you about everything in detail, but right now I am talking only about the classification. And the submucous can be sessile or pedunculated or a polyp. What do we understand by sessile? Anything which does not have a peduncle is called as sessile. There is no neck portion. But anything which is hanging with a small neck is called a polypoidal growth, and this is called as a peduncle. So in submucous cases, some of the submucous can be like this, which are sessile, like arising from the mucous layer itself. Sometimes they may come like this and lie inside the endometrial cavity. So then it becomes pedunculated or a polyp-like submucous fibroid. This was all about the body or the corporeal fibroids. But if we'll be talking about the cervical, see, I can make the diagram over here. This is the cervix. It is a very narrow tubular structure. So it only depends on the anatomical position. in gynecology, we talk about the anatomical position when the patient is lying in the lithotomy position. So just think that your patient is lying in a lithotomy position. So your cervix will look like this after a perspeculum examination. So anterior and posterior, central, and both of these become lateral. जो आगे से आया from towards the abdomen, it is anterior, from towards the back, it is posterior, towards both of the legs, lateral, and the central one which looks in the center of the cervix. So the anatomical location is anterior, posterior, central, and lateral. This whole depends on the location of the fibroid, and because in ultrasonography we can very wonderfully make out what is the location of the fibroid, this classification works very well. Now this we were talking about. See in this picture, this is your uterus. We have taken a cut section of the uterus. So this blue thing is the endometrial cavity. This black lining just beneath is the mucosa layer or the endometrium. This pink thing is your myometrium, and this black lining with the skin-like structure above is this is the peritoneum layer, so this becomes the serosa, right? Look at this fibroid. What was this fibroid? I must tell you that every fibroid is born intramurally or interstitially because it arises from the smooth muscle and the fibroid tissue of the myometrium. So a fibroid is born like this at this place. If it moves towards the serosa, it will become subserous. So if it moves like this and stops here, it is a pure subserous fibroid. But if it acquires a peduncle, what does that mean? That see, this is the peritoneal layer, the skin color thing. So if the peritoneum is partially covering this fibroid, it is subserous. But if it completely covers it and then it forms a peduncle, it contains only the peritoneum and the feeding blood vessels. So it becomes a subserous pedunculated fibroid, right? If this fibroid grows towards the broad ligament, it becomes a intraligamentary subserous fibroid. It is a subserous fibroid which grows from the uterus, but it moves towards the broad ligament and it becomes intraligamentary subserous fibroid. While you are operating such a patient or you are doing a sonography, you can say that, oh, this is a broad ligament fibroid because it is located inside the broad ligament. But mind it, it is a pseudo broad ligament fibroid because it is coming from the uterus. It is lying in the broad ligament, but it is coming from the uterus. Some of the fibroids, they arise truly from the broad ligament. So they are true broad ligament, but this is pseudo broad ligament. And this subserous peduncle with the blood vessels, sometimes it gets cut off from this place. It becomes so thin that it gets cut off. And this fibroid gets attached either to the omentum or any other abdominal structure and starts taking its blood supply from that structure. So this fibroid becomes detached from the parent body and it becomes a parasite on the other abdominal organ. So it is called as wandering fibroid. Wandering, घूमता हुआ fibroid or a parasitic fibroid. So these, in the classification, we read about this classification. What does that mean? Wandering means away from the parent body and attached to some other structure. And why parasitic? Because it is taking its blood supply from that other structure. Now submucous. If this intramural fibroid goes towards the endometrium, it becomes a submucous. It is a pure submucous. But if it gains a peduncle and it moves out like a polyp, it becomes a pedunculated submucous fibroid. So according to the anatomical location of the corporeal fibroids, we can see that there are the different kinds of fibroid which you can find in the patients. This is a true picture of a uterus, a specimen. See, this is the cervix. This is the cervix and this is the uterine body. And then there are 1, 2, 3, 4, 5, so many fibroids. Some are subserous, like all of them which you can see are subserous. Some may be intramural, which we cannot see but we can feel during the surgery. This is the fallopian tube and this is the ovary. So the uterus is actually shattered in anatomy because there are so many fibroids which has actually deranged everything about the uterus. This is a cut open section of a uterus. Cut open section because you can see that this is the myoma. Can you see? There was the specimen which was being cut open like this. The anterior wall is cut open. You can see the fallopian tubes by the side, the cervix open up here. This is the cut open endometrium and a big fibroid is protruding out of that endometrium. So it is a submucous fibroid. Now this is a FIGO classification of fibroids. This is now used by the sonologist, by the gynecologist to exactly do the fibroid mapping, that at what place the fibroid is there and how much operable is the fibroid, because nowadays there are so many techniques by which we are operating the fibroids. Earlier we used to put an incision on the abdomen, open up the this abdomen and take out the uterus, this fibroid. But now we can go laparoscopically, we can go hysteroscopically. So by this fibroid mapping we can make out that which is a better approach to operate this patient. Now we'll study this FIGO classification in detail. SM means submucosal fibroid, O means other, and then there are hybrid leiomyomas. So if you will study a sonography report of a patient of fibroid, then they mention all these things. Submucosal, there are three categories, 1, 2, 3. Sorry, it is 0, 1 and 2. So 0, 1 is pedunculated intracavitary submucosal fibroid. 0, pedunculated totally inside the cavity, inside the endometrial cavity. Then 1 is actually a submucous fibroid with less than 50% of the body lying inside the myometrium. It is still attached to the myometrium but only the less than 50% body. So this 0 and 1 are easily operable hysteroscopically. Hysteroscope means it is an instrument which goes inside from the cervix and then shaves off this uterus, this fibroid. So this fibroid 0 and fibroid 1, more or less they are lying inside the cavity, so they can be easily shaven off by using a hysteroscope. Then comes 2, it is also submucous but more than 50% of the body is lying inside the myometrium. So 0, 1 and 2, they are submucous fibroids. Then others are 3, 4, 5, 6, 7, 8. 3 contacts the endometrium but it is 100% intramural. What does that mean? It is 100% inside the myometrium but a part of it is just touching the endometrium. 4 is a pure intramural thing. 5, it starts moving towards the subserosal layer but more than 50% is inside your myometrium. 6 is again the subserosal but more than 50% has gone away from the myometrium. 7, it is pedunculated and there is a specific peduncle, which a subserous thing which has got a peduncle. But 8 is a parasitic or a cervical thing which is not attached to the myometrium at all, not attached to the uterus, and it is taking its blood supply from the adjacent structures. So these are 0 to 8 classification of the fibroids. Now what are hybrid? Hybrid are those huge fibroids which cannot be categorized in a single thing. For example, here 2 to 5 is written. What does that mean? The first word indicates the relationship with the endometrium. So that means 2. This is 2 to 5. It is a big thing. 2 means it is lying here near the submucous thing, and 5 The second one indicates the relationship to the serosa. 2 to 5 means it is touching the submucous area also and the subserous area also. So you should understand that it is a big fibroid which is extending from the submucous part to the subserosal part and obviously covering the intramural region also. So with this we finish the FIGO classification of the fibroid. Then there is something called as Wamsteker's classification. It is the 0, 1, 2 of the earlier FIGO classification which I was telling, but it is only for the hysteroscopies. Hysteroscopic, what I told, we go from the cervical canal. So only the 0 and 1 are completely and easily operable by the hysteroscopic approach. 0 means pedunculated submucous which is totally lying inside the endometrial cavity, and 1 is a submucous fibroid where more than 50% is the portion is inside the endometrial cavity, and 2 less than 50% of the portion is inside the endometrial cavity. So the hysteroscopic classification is the Wamsteker's classification. Now we will be studying each and every type of the fibroid in little bit of detail, which is important from a clinical point of view, from the clinical scenarios, because the history arises from this, for the PG students also and from the theory examination part also. Interstitial or intramural, most common 75%, remember this percentage. Initially the fibroids are intramural, what I talked about. Every fibroid is born inside the intramural area, but subsequently some are pushed towards the serosa or inwards towards the endometrium. Eventually about 70% persist in that original position named as interstitial fibroid. Then comes your subperitoneal or subserous or 15%, what we were talking about. In this condition, the intramural myoma is pushed towards the peritoneal cavity. I have talked about it very nicely from the diagram, that the intramural thing is pushed outward and it starts lying subserosally. The fibroids are either partially or completely covered by the peritoneum. If partially covered, then it is still subserosal, and if completely covered, that means it has become pedunculated. When completely covered by the peritoneum, it usually attains a pedicle and is called as the pedunculated subserous myoma. On rare occasions, the pedicle may be torn. I told you that this was a pedicle, and on rare occasion it may get torn. The fibroid gets its nourishment from the omental or the mesenteric adhesions which are lying side to it, and is now called a wandering, a structure which has started wandering, or a parasitic fibroid which has started taking all the nutrition from the neighbor. The intramural fibroid may be pushed out in between the layers of a broad ligament and is now called a false broad ligament myoma or a pseudo broad ligament myoma. See, these are your broad ligaments. A very wonderful thing is this, that if we remember our anatomy, the uterines come from the anterior division of the internal iliac artery. They go towards the uterus. At the level of the isthmus, they turn upwards and they move like this. At the same time, the ureter is also coming from the kidney, and at the level of the isthmus, it crosses under the uterine artery and then it goes towards the urinary bladder, right? So isthmus is a very important anatomical location from a gynecological point of view. At this point we ligate the uterine arteries. At this point the ureter crosses the uterine arteries, and we can injure the ureter if we are not very careful. But what happens in a case of a broad ligament fibroid? If there is a subserosal fibroid at this location and it starts moving towards the broad ligament, what happens? It comes here. So the ureter lies lateral to this fibroid. So in a pseudo broad ligament fibroid, you will always find the ureter lateral to the fibroid, right? And it pushes and compresses the ureter. But if it was a true broad ligament fibroid, that means the mother structure was broad ligament, so it will arise from here. So for this true broad ligament fibroid, the anatomical relation of the ureter becomes a medial one. So this is the differentiating feature of a pseudo broad ligament fibroid and a true broad ligament fibroid. If the ureter is lateral, it is a pseudo one. If it is medial, it is a true broad ligament fibroid. This is a very important exam question. These myomas, we are talking about broad ligament myomas, pseudo one, are difficult to differentiate from a solid ovarian tumors, because solid ovarian tumors also arise from the adnexa and they grow towards the broad ligament, and similarly it is also growing. So in your radiological findings they appear the same. These myoma may cause hydroureter, definitely, because the ureter is lying so close, it compresses the ureter. And since it compresses the ureter, the kidney thinks that there is some kinking, there is some problem. So it started releasing the erythropoietin factor and the patient may get polycythemia. And sometimes it also causes a pseudo-Meek syndrome. What is pseudo-Meek syndrome? Generally in cases of fibroma of the ovary, you find a Meek syndrome where there is pleural effusion and ascites. But in these cases it is pseudo syndrome, that in this the broad ligament fibroid you can find ascites, you can find pleural effusion, but this is not an ovarian tumor. So a broad ligament fibroid usually causes a confusion between ovarian tumor and a fibroid. A true broad ligament fibroid arises from the broad ligament and it is lateral to the ureter. That means the fibroid is lateral to the ureter and ureter is medial. I draw this diagram. This is ureter. The fibroid arises laterally to the ureter. It can cause polycythemia because of the compression of the ureter and release of erythropoietic factor. A false or a pseudo broad ligament fibroid is actually a subserosal fibroid which goes into the broad ligament and it is medial to the ureter, right? Submucous fibroids. Submucous fibroids, the incidence is the rarest, 5%, but the fate is the worst. The worst fibroid which always produces symptoms and which can cause maximum damage to your patient is a submucous fibroid. Why? Because endometrium is the functional layer. So it is getting attracted towards that endometrium and it is causing problem to that endometrium. The intramural fibroid, when pushed towards the uterine cavity and is lying underneath the endometrium, it becomes a submucous fibroid. Now if we understand that whole functional thing is going on over here, the menstrual cycle is going on over here. So the final fate of submucous fibroid, it can get necrosed. The surface area, here the blood supply is very less. So necrosis may occur. Sometimes it becomes polyp and starts coming out from the os, causes extreme problems to the patient. It may get necrosed, it may get infected, and the degenerations may cause sarcomatous change. So the percentage of changes towards the sarcoma are maximum in cases of submucous fibroid and it produces the maximum symptoms. So out of all the fibroids, at the given size, maximum symptoms are produced by the submucous fibroid, including necrosis, infection, polypoid change, sarcomatous change. Now come your cervical. Cervical are very less, only 1 to 2%. And as I told, depending on the position, like we are seeing the cervix from down below, this is the anterior, posterior and lateral. And if we see inside the abdomen, if the cervix has got a fibroid, so the maximum problem is caused to the ureter because ureters are lying close by. So the maximum chances of getting an ureteric injury are in cervical fibroid or broad ligament fibroid surgeries, and it can easily cause a hydroureter. What is a pseudo cervical fibroid? Pseudo means false. So a fibroidal polyp, sometimes a fibroidal polyp which is actually arising from this, the peduncle is here, it grows and starts coming out from this place. So you can say, oh, it is a central cervical fibroid, but no, it is a pedunculated fibroidal polyp which wants to come out from the cervix. So it is a pseudo-cervical fibroid. A fibroidal polyp arising from the uterine body when occupies and distends the cervical canal, it is called a pseudo-cervical fibroid. Now at the last we will be talking about the pathology, that in a pathology specimen when you see a fibroid, what you see? The cut appearance. The uterus, it will be distorted, the shape will be distorted, the feel is firm. Generally, the myometrium is easily compressible, but no, a fibroid is firm. The cut surface of the tumor is smooth, important word, whitish, and whorled appearance. What is the meaning of whorled? Whorled means it looks like this, whirlpool, round. So the myocyte, the monoclonal thing, one layer, second layer, third layer. So it is a round, closely woven whorled structure, smooth, whitish. And because it grows like this, it compresses the normal myometrium in the periphery and forms a false capsule. The false capsule is formed by the compressed adjacent myometrium. The capsule is separated from the growth by a thin loose areolar tissue. In the myometrium, this is the round whorled fibroid, and this is a false capsule which has a very loose areolar tissue around. It is through this plane that we go in the surgery of myomectomy. Myomectomy is a surgery of taking out a fibroid. So we have to dissect out this space which gives rise to least bleeding. The blood vessels run through this plane to supply the tumor. It is through this plane that the tumor is shelled out during the myomectomy surgery. The blood vessels generally come from this place, so the center of the fibroid gets the least blood supply and the maximum degeneration and changes occur over here because of the least blood supply. What is the microscopic appearance? Microscopy, you will find smooth muscles because it is a muscular tumor, and fibrous connective tissue. Only two things to remember from this topic: smooth muscles and fibrous connective tissue. So a fibromyomata or a myomata is a better word. So in your naked eye appearance, whorled appearance, whitish appearance, false capsule, that's it. And in this microscopic appearance, smooth muscle and fibrous connective tissue, that's it. So with this, I finished the first part of the fibroid, where we were talking mainly about the etiology and the classification. In the concluding lecture, we'll be talking further about the symptoms and the treatment. Thank you very much.